Thank you very much, Matt, and good day to all of you. Um, how things have changed in the recent month. Earlier, we used to shake hands, and that phenomena may be something of the past. And similarly, in the group here, we have people from all parts of the world. So again, instead of saying good morning, good afternoon, good evening, or anything in that nature, maybe we'll adopt good day and other kinds of conventions in times to come. So I wanted to begin by showing you some slides, and then we will go directly to question and answers. So okay, so this is the topic for our discussion today. And as we were talking about just now, how much has changed in the last month? One of the things which is there is that people now look upon telehealth as a service which can be done across state boundary lines and possibly also across national boundary lines. And the government goes ahead and announces this new opening. And I get a call from a doctor in Maine who had spoken in my class. And he says to me that on one side, I see this announcement for the federal government that we can offer these services across state boundary lines. We don't have to worry about HIPAA. My own hospital is telling me that we shouldn't do that. We can get into problems with it. What is the reality? And I started my answer with, well, both of them are right. And he seemed confused. So on one side, we are having these opening of market. On the other side, a lot of new issues have come up. And some of these we'll probably discuss in our session today. Similarly, there's a lot more money being invested in telemedicine companies suddenly. At one point, people found it difficult to get VC money. And now it's gone the other extreme. A lot of people are there, a lot of questions are being asked, what can be done? And the reason I say it's in the extreme is that all these companies in telemedicine are trying to address one particular niche of the problem. They're looking at one medical disease or one medical symptom or one class of population. If we really have to succeed this as a society, become a truly digital health society, then we really need to think of an integrated strategy, how these things can work together, what can be done. Otherwise, it will be very difficult if we expect a patient to use 20 different gadgets and apps. So this is an issue which again, we'll take up for further discussion based on your interest. And as far as startups are concerned, I do want to mention that in my experience, companies, startups, countries, empires, they all go through 4 stages. And in the first stage, the emphasis is on getting the work done. Don't worry about other factors, just get the work done. If you have to kill a lot of people and setting up a new empire, don't worry about the number of people killed, just get the territory. If you are a startup, just get something done so that we can get VC money, we can get to the next stage. The second stage is that get the work done and try to follow whatever rules are there, try to minimize the number of casualties. And the third is that try to make sure that you follow the rules, and the rules are not just the external rules. These organizations, whether it's a company or a country or an empire, they come up with their own kinds of rules and make sure you follow those as well. And in some cases, they'll give priority to their own rules as opposed to what may be required by other procedures, international conventions, or corporate guidelines of the country. And the fourth stage is that follow all the internal rules, follow all the external rules, and it doesn't matter whether the work is done or not. That does not count anymore. So I see organizations right now at all these 4 stages. And again, in the healthcare area, it's very nice to see that we have a new influx of organizations at the first stage. And hopefully that will lead to more things being done in reality rather than organizations who are catering, who are at the fourth stage at this point in time. I'll give you an example of fourth stage. This relates to a big empire before the First World War, a fairly powerful one. And it used to be much powerful earlier, and it had a police system, and the police was corrupt. And the organized empire went ahead and created a second layer of police saying that we are going to take care of it. The second layer was also corrupt. So they started with the third layer, and then they started with the fourth layer. So now one had to drive 4 different layers of it, and not one of them would do anything because they expected the others to do it. And that's why having more layers of control and more layers of things is also an issue which one needs to take care of. And when crisis occurs, some organizations will go ahead and take a much more decentralized approach, and some people will take a much more centralized approach. We saw what happened with the Tsar in the First World War, that the crisis occurred, he took all the powers at his own level. And that essentially led to the execution of him and his family in such a brutal manner. So one has to be careful how much we want to do, how we want to do it, and be careful about the kinds of precedents we set during these pandemics or during these crises. So talk today is geared towards three kinds of issues. The first issue is that what does healthcare telehealth mean for me and my family? The second is what does this mean for my company and what is the critical success factor for success? And the third one is how can we help to achieve the goals of healthcare for all our employees, better, cheaper, and less expensive. These are for organizations which are not in the healthcare area. And furthermore, these organizations, some of them are losing their traditional business, the traditional base. How can we leverage our corporate assets to leverage the sudden interest in this area? So those are the kind of things that I'd like to take up for discussion. And again, I welcome any questions, any comments that you have. That's basically what the session is for. And in the current climate, I'd like to describe one approach which was proposed about 20 years ago, which distinguishes it, between three kinds of resources in healthcare. One is on-site personnel. It could be a family member, it could be a nurse practitioner, it could be a technician, it could be a medical doctor, primary care doctor. The second asset that we have is the off-site personnel. These are the domain experts for the particular size of symptoms. They be based in the same city, different county, different state, different country, and they are the ones who would be really the expert helping you. And in the current context, we see that organizations in the US, some of them have gone ahead and set up a two-tier system where the patients meet with certain persons who took care of them, but the expert medical doctors are kept distance from them, so they are relatively immune from the infections and they can practice without being distracted. As computer AI and data mining are all the offsite data crunching centers, data analytics centers is there. And in my definition, anything which meets two of these three criteria or has two of these three rounds form the definition of telehealth. So my definition of telehealth is much broader than what people may have used or what you may have seen in the past. And as we start thinking about what can it lead this three-pronged approach, or what can this coronavirus pandemic do, I would like to emphasize that we are seeing it impact all kinds of things. If we have patients, we don't know whether they have coronavirus or not. In the old times, the standard was, well, if you don't know, just come to my office, the doctor will take a quick look. To the other side, saying, well, you stay where you are, let's talk over the phone, let's talk over video, let's talk through other technology. The second prompt is in terms of the knowledge systems which are available. In coronavirus, we find some good information, but we also find some terrible information, which is totally wrong, totally incorrect. But again, even the same organization changes its viewpoint. CDC, for example, at one side said that wearing a mask can increase the infection rate. Then it was neutral. Then it says, oh, wearing a mask is helpful. And then the president says, well, even though this advice has come, I'm not going to follow it. So we have all these kinds of different things. How do we really take it in a digital environment so that we can give quick, proper information to people? In the old days, we trusted the doctor. The doctor was supposed to be the repository for such information. We relied on the doctor. Today, we have to rely on these automated techniques. And I like to distinguish these kinds of approaches into four major categories when we think of it on a global basis, on a macro basis. The first area is knowledge acquisition. We have so much information on paper, we have so much information in computers, we have so much information online. How do we really acquire this information? How do we really extract this information? How do we take care of it in a meaningful way so that we can share it with others in society? The second part I just want to distinguish is knowledge discovery. How do we take this huge amounts of information, acquire additional information, knowledge from this information, all the data mining aspects, all the artificial neural networks and all, they fall into this category. And as we look around, we find these things are coming up, but there's relatively little which has been done in terms of the quality of these services, the performance of these services, the safety of these services. And my concern is the way things are going. On one side, we have different countries trying to have regulation. On the other side, some of these things are just being neglected, and these can create problems. After 9/11, a rule was made that only the pilot or the co-pilot will have the keys to enter the cockpit. Worked fine, made sense. And then we have a case where the pilot went to the bathroom, the co-pilot had medical problems for a long time, mental issues. he basically crashes the plane. It was a Lufthansa plane with more than 200 people. So these new technologies, on one side, they're good. On the other side, there are also issues which are there. And so far, we have not gone ahead and addressed them in any meaningful way. Uh, until 2012, there was a national directory of disbarred doctors in the US. Anybody could use it to do telemedicine, to see a doctor's credentials. Because of pressures, and you can think from whom, that directory is no longer published after 2012. And we have cases here of a doctor who has been disbarred from service in 3 states of the country and is still practicing in a 4th. And by the current regulations, that person can practice anywhere in the patient can be anywhere in the country. So these are issues we have to also think about in terms of knowledge discovery, not just the disease type of things, but the other information. The third aspect I'd like to emphasize is the notion of knowledge management. We have so much information. We have seen all this thing about electronic health record, the Fortune article last year where it says $35 billion have spent in the last 10 years in the US alone. We are nowhere closer to a solution. We have actually made it worse. Internationally, all people are going ahead. It's a total mess which is there. And we can talk about it further, what can and should be done in this area. And the fourth area I'd like to specify is the area of knowledge dissemination. That once you get this information, how do you spread it around? How do you share it with fellow citizens? And I'll give you one example. At the time of the Grenada War, the pilots in the air could not talk to the soldiers in the field. So, and after the war, they said we should have better integration of information between Army, Air Force, and Navy. And my group got drafted to work on it to help out on this mission. And I learned a lot from the experience. One of the things that I learned is that if a pilot is on a bombing mission, we want to give as little information to that pilot as possible. A lot of information is just a distraction. We don't want to do it. How do we attain the same goal in the medical field? If somebody is in emergency, do we want to flood that person with even more information or with less information? So these are some of the issues that you might like to discuss, and I just gave you some pointers or issues. At this point, we are going to take a brief poll to see how you feel about some of the issues related to telehealth. So I'll request my colleagues to put up the poll up, and if you can kindly respond in about 2 minutes time, then we'll give the results from the poll and go ahead with the questions and answers. These are very 4 quick questions, and just use your judgment. In many cases, you either know the answer or you don't know it, kind of a thing. So again, please go ahead and do this question at this point. Thank you. And if you finish the questionnaire, please go ahead and start entering your questions in the chat field so that my colleagues can go ahead and collate them and start asking them. And again, Matt, while it's nice of you, I think it's better that we leave in terms of what is announced, we do not use either the name of the organization from which the person is, because this recording is most likely going to be taped and placed online. I don't want to get any of those issues of confidentiality of that information. Thank you. Okay, great. I think you've got a chance to look at it. Can you share the results now? Or you want to do it later? Matt can start with some questions. Matt, you come up with it. Okay, great. Thank you.
I'll share them. Yeah, take a look.
Okay. So interesting. Really interesting the kind of answers you've given. The first answer, I'm really amazed that all of you have gotten it right. The answers to the first 2 questions is actually 0 and 0. By 0 and 0, I should tell you that in the case of the first one, the patient was actually located in Cambridge, Massachusetts. And most of you have said it's within 50 miles of Cambridge, which is very appropriate, very nice. Alexander Graham Bell at that time used to be affiliated with Boston University. He was on the Boston side. At that time, MIT was not on the Cambridge side. It was on the Boston side in a small building. BU was actually the leader at that time. Not Harvard was there, BU was there, but MIT was still in the early stages. And his assistant Watson was on Main Street in Cambridge, right near where Fulbright building used to be. And they were practicing for the first time a 2-mile connection of the telephone system. So the assistant spilled some acid, and when he has spilled the acid, Alexander Graham Bell gave him advice about what he should do. So that is the first recorded event in which the telephone service was used to provide telehealth services. The second one, it's all over the place. A lot of people have said 1900 AD and all. Actually, the answer is 0 minus 0 again, because the year in which this demonstration took place between Alexander Graham Bell and his assistant Watson is exactly the same year in which the patent was issued. Both the things took place in the same year. So the third one, where Massachusetts stands in terms of ranking of the innovations relating to telehealth among states, you are again right. Massachusetts is among the leading states. It's among the top 25% of the state. Most of you got it right. And the fourth one, which is there, you'd be surprised that the bulk of you are wrong, or the overwhelming number of people who are attending this session are actually wrong. Massachusetts is among the bottom 25% of the states. It's among the last ones in terms of use of telemedicine services. So this just shows the difference between the innovation aspect and the deployment aspect. We at this point have a number of countries which are ahead of the US. And in terms of the US, the western parts of the US is much more advanced than the eastern part. And among the eastern part also, Massachusetts is among the most lagging states. Things have changed a little because of the coronavirus, and we are hoping it will catch up. But again, there's a major opportunity for people around to think what can and should be done and why it is there. Thank you very much for your inputs. Um, Matt, you want to start with some questions, and then we'll go to some others.
Yep, absolutely. So one question we have is, what areas of the private sector have shown the most interest in taking a deeper look at telemedicine during the pandemic? And will it result in permanent change in federal state policy moving forward?
Well, in terms of private sector, I would say it's a fairly broad attempt at this point. We have private practitioners who are going ahead and doing it. At the other extreme, we have a company like Teledoc, whose share has jumped up a lot. And we have all kinds of companies who are trying to enter it. We are going to go through a consolidation phase. And again, I advise people who are trying to start companies now to see what they can do in terms to have a macro approach instead of just going through one constituency, one geographic area, what can be done in it. As far as the state and federal laws are concerned, I think it is a very welcome sign that things have changed finally. 10 years ago, I wrote a paper in a law journal saying that all the restrictions imposed by state governments on interstate practice of telemedicine, they violate the interstate commerce clause of the US Constitution. All these laws are illegal and inapplicable. 3 years ago, the Department of Veterans Affairs accepted it. Other government agencies have not fully embraced it, but because of the emergency, they've given emergency powers to be able to use it. States, on the other hand, are again at varied stages. Some are more receptive. They've set up local compacts. One of them is a larger compact, but some states have still not fully endorsed that idea. And even the idea of telemedicine parity act, it was done in most of the Western states. Massachusetts has been one of the lagging states in this area. So again, it varies a lot, and it's really ironical that the kind of disparities that we see in terms of it. But mainly, I would say, is the private sector which has taken the lead on this in this country, whereas in other countries the situation is very different. I can give you one example of a country whose annual medical spending per citizen is only $300 per year, as opposed to the US, which is 10,000. And they give free service. If somebody has cancer, for example, that person's record can be given by that patient, and they will be seen by the top cancer specialists in the country through electronic form without any charge to the patient. So foreign countries are much more advanced in this area at this point. Okay. Next one, Matt.
Yep. If you could expand a little bit more on what you think perhaps it would take for Massachusetts to advance a little further with this development.
Well, I think in terms of development, in terms of innovation, it is proceeding very well. In terms of deployment, there has been generally a reluctance on it. And let me start with saying which states have been the most advanced and why, and that might give you a clue on what can and should be done. The most advanced states in terms of use of telemedicine today are states like Alaska, Hawaii, Arizona. And in each of these states, the major factor or the critical success factor in these states was a university played a major role in doing this deployment. And in the university, there were people who were from the medical field, people from the technical field, people from the law field, people from the business field, public policy field. They all worked together in order to attain this success. And in some cases, it was almost an incestuous relationship. Like in Arizona, where I spent a few years, my colleague, who was the Dean of Public Administration, was concurrently the State Commissioner for Rural Health. And this kind of relationship held. In Massachusetts, on the other hand, first of all, we don't have a public university which has all these schools in one place. And the private schools which are here, Harvard, BU, and others, they simply are not interested in getting involved in these kinds of efforts. The emphasis in all these schools is to have very specialized domain experts. They've done phenomenal work in medicine, in computers, in business and all, but being able to reach out, developing a strategy and all, that has been in the back burner. That has not been given any priority, no attention. And in fact, people who are doing this kind of work are not treated in the proper way in terms of helping them and all. So that's where I think somebody has to take the lead in order to foster this kind of relationship in order if we want to change in this direction. And emergencies is one of the best ways to do it, which is what I've said on the 4 stages of evolution and growth and decay.
Great, thank you. In terms of individuals and corporate employees, what will telehealth mean for, me and my family?
Well, it's a very interesting question, and I think it's partially related to the way the healthcare is in this country. And again, it's different in other countries, and I'm quite willing to extend that my answer to cover other countries as well. In this country, we basically have systems of private health insurance companies and the government providing also some support. And each of them has been entrenched in one particular area. Most of them are state-based, which was one of the earlier ways we used to be there in financial industry as well. We can learn a lot from what happened in the financial industry to motivate growth. Each of them has independent systems. So the first thing which creates problem is the sharing of records. If you're going from one place to another place, you're dealing with a different health insurance company. Even though they claim the records can be seen, it's very difficult to get all the systems of it. So what telehealth gives the opportunity is that irrespective of where the person is, one can go ahead and use it. And I think for very big companies, instead of going through each of the health systems, one can think in terms of having nationwide telemedicine companies which offer both in-house services in terms of face-to-face as well as telemedicine, as well as I would add one more feature, which is called the medical tourism, people going from one state to another state or one country to another country to get services. That kind of blending is going to take place over time, whether they like it or not. That's going to be the reality of the marketplace. Now, in order to support that work, we have to have better ways of sharing the information. The healthcare interoperability aspect again becomes important. So we have in the local area a person like Atul Karwarkar who's working with JP Morgan and Amazon to see whether this kind of method can be there of offering healthcare services, which actually is more organization based. Amazon wants to offer it to all its employees. JP Morgan wants to offer it. So those kinds of things are what will come up, where the organization should be the one taking the leadership in it, deploying it, setting up these healthcare plans. They will save a lot of money through this method. They'll be able to get better services. And as the employees travels across states and across countries, we'll see seamless access to services. In some cases, it's through telemedicine, and in some cases, it's through face-to-face interaction in that respective state and country. That's the kind of revolution we're going to see coming up as individual company as a concern. And also, I would say that the side benefit to it, which I think is very important, is that over time, I think if used properly, this can actually reduce the kind of corporate burden which is there related to healthcare. In the past, I've heard numbers anywhere that for every car which is manufactured in the US, the healthcare burden per car is anywhere between $5,000 to $20,000 per car. That's the amount of money which is being spent. That is far higher than anywhere else in the world. So that makes US products and services less competitive in the global marketplace. So that would be one side benefit. In contrast, in the other countries, most countries, we seem to have a two-level system. One is there's a public system which is free or close to free, and then there's a private system which goes on, which works almost on a capitalistic kind of a basis. The more money you're willing to spend. So there, the motivators are very different about how it can be implemented. And then we have countries in Africa and others where again we are looking at what can be done, what should be done. And I'm really impressed with what some of these countries have done with respect to use of telemedicine at this point.
Great, thank you for expanding on that. One question I received, how would telehealth adoption be among the Medicare demographic?
Well, I think right now what's happening, we have actually done a study, or my students have done a study, where we have actually seen what is happening with respect to Medicare and Medicaid. And I forget which one was what, but in one case, I think the payment is made based on where the patient is, and in the other case, the payment is made based on where the physician is. So these kinds of anomalies exist We also find rate differences are there between states for payments. And again, we think that by taking a national approach to it, we can actually use the arbitrage method of getting the best services, quicker services for the patients instead of having them to wait for a long time. They can go ahead and do it much more quickly, more efficiently. Those are the things which would happen. But again, the way our system is laid, it's not something that the unilaterally the federal government can do by itself. The federal government and the state governments have to work together to implement these changes. And that's where I find there's a total vacuum at this point in terms of doing it. And the best way to do it is either the defense forces taking the lead and implementing it first, like the VA has done, it can serve as a role model for others. Or the other way is a crisis like this, where things are done on an emergency basis first. People think they work very well, and then they try to apply it for other things.
How is the fragmented health history data impacting the quality of telemedicine?
Well, the fragmented health data is impacting it in many, many ways. The first thing it does is that in the case of the coronavirus, for example, a number of people shared their draft plans with me about what they are recommending to the state government and the federal government. So suddenly they wanted me to look at it, especially with my telehealth background. And one of the plans which I saw, and I don't want to mention which institution it was from, it basically said that when we are doing these treatments, we will forget about the patient's old history altogether, and we will just do it as if the patient is there for the first time, disregard all the past history, we'll do it. And after this effect takes place, we will forget that history again, not integrated it. That's the simplest and easiest way to do it. I think there are a lot of flaws with that kind of an approach. A person may have some kind of conditions which render the normal way of doing not possible. Secondly, there might be kind of other things which they have to take care in terms of blood pressure, heart rate, and others. So that, according to me, was not a way to do it. And again, it is people who are not familiar with the realities of the ground who may are making these kinds of decisions. A few years ago, the NIH had actually sponsored a study under my group on how to have agile integration of information in crisis situations like the current one. And we had made a recommendation about how it can be done, what should be done. We should forget about patient consent and things like that. And I wish they had taken it more seriously at that time, but things were all normal. Nobody really worked on it. And I think the other problem it causes with the way it is that right now you go to a room, emergency room, and you can have a situation where they are really packed up, they're backed up, and they're sent away. I remember in Arizona, I had two students. They got burnt in the kitchen in the emergency wing. It took them 12, 15 hours before they were looked after and treated. South of the border in Mexico, there were hospital, private hospital owned by an American company, which has one nurse for every two patients, one doctor for every five patients. They have a guaranteed response time for 10 minutes. So in some of these cases, using telemedicine, at least whether it's across states or across country boundary lines, even in cases where surgery has to be done, that can be using as a triage mechanism so that at least the patient can get some drugs, some painkillers and all, and yes, you can do the surgery later. So these are the kinds of things where I think telemedicine will help, whether it's a consultative kind of affair, whether it's a surgery kind of affair. And the other thing which should also be remembered is that we should not just think of the encounter of telemedicine on an isolated basis. We should also take into account the cost incurred in terms of a person going to a hospital. Normal case, you take a child to the hospital, one of the parents has to take their day off, how much cost is involved, what is the impact on society. We've actually done studies like this in my group to see what can be done. And this other issue is that there is a very finite, it's a small one, but there's a finite percentage that if you go to an emergency room, the infection you catch there is more serious than the one you are gone for. And these kinds of incidences also increase the cost as a system, both to the person concerned, inability, as well as to the society as a whole, the country as a whole. So these are some of the issues to keep in mind when one thinks of in terms of telemedicine deployment.
Great, thank you. Do we foresee any changes to the health insurance firms and policies post-COVID?
It's hard to say at this point. The reason I say it is that right now people are looking at what should be done in emergency, and I entirely agree that that should be the focus on it. But at some point, the issue will come back that how much was spent on COVID, and was there a better way to manage it? How did other countries manage it? Is there a better way of doing it? I should tell you, in 1919, when the last pandemic or global epidemic took place, it lasted for about 2 to 3 years. And the net impact of it was that many of the European states, which had totally resisted the idea. They all went in for state-sponsored healthcare for all their citizens. That's what they ended up doing. Now, I don't think it will happen here in that mode, but I think there will be radical differences on what is done, how it's done, and who does it. So time will tell whether it will be taken, and time will again tell whether it's done in the way where it really makes difference, leads to positive things, or whether it's done more for political reasons. Recently, for example, I've been asked this question repeatedly about what do you think is a good role model for systems with interoperable. And for years, I used to give the VA systems, Vista system as being the role model. When Katrina hit Louisiana, all the other systems died. The only systems which continue to work was the VA systems, and others have written about in literature. Australia was coming very close to it, of taking this as a national standard for the country. The prime minister had made a thing, but he got voted out. The new prime minister didn't take it. It had a lot of respect and all. And under the current administration, for political reasons, they made a decision, and that's done on a non-competitive basis, to basically scrap the VA system and take a system for Cerner for about $15 billion. So again, I would say that, yes, things will change, but how they will change or in which direction it will change in terms of partnership, time where I thought the federal government will take more steps to have interoperability of information. They basically gone the other direction of privatizing more. So maybe here it will lead to more privatization. It's too early to make those judgments at this point.
In terms of companies involved in healthcare and telehealth, can you go into more detail about what that means for each company and the critical success factor?
Well, I would prefer not to have me give opinions about particular companies. They are competitive companies, and I think it's unfair to do it unless something is really stands out, like in the case of policy decisions with the government. I would say that the companies, I can break them into several categories. One is companies which are taking care of consultations on an asynchronous basis. Dermatology companies, for example, are doing it on that basis. You can particular thing to send a photograph, the dermatologist sees another thing, you get you, so you don't have a face-to-face consultation in that sense. And then there are companies which are going after the synchronous market where both sides are at the same time. Then we have companies which are going in for different specialties. Last night we were working with a company which is in the area of stroke and neurology, how they're doing it through teleneurology, where even if you go to a hospital which has a neurologist that in hospital itself to take care of stroke things, versus if you do it on telemedicine, we actually find the telemedicine thing works quicker and better rather than having a doctor in place. So those are things which are going in different areas. I have a student of mine who has gone ahead and designed a bra which the lady can wear to office and work. And during the day where she's at work, it captures all the lung information and heart information. Another one who has developed a teledentistry application, and he claims that his thing outsmarts all the dentists in the world. That's what he claims as technology. So some of them have gone for very specific niches which are there. Some of them have gone for very small geographic areas which are there, and some have gone for much larger ones. And again, we see, my opinion, frankly, is that early on, when I tried to propose the idea of laptop computers, and I can say it because I've discussed it and we have joked about it, one of the very large companies told me, we are not in the toy computer business. If you want to deal with toy computers, go to apples and oranges. And I wish I'd taken that advice to go to Apple at that point. In this area, I still find that companies are thinking, have a very short-sighted kind of view. I still don't see a long-term vision from it. And again, it's very possible that a company like Facebook will come in from behind and actually outsmart all it and become like a global or a national or as a global standard. So that's all what I want to comment. I don't want to take specific names about American Well or Teledoc or anything else where they stand and what they see the future for each of them.
No, yeah, that's totally fair. Can you talk about how we might be able to leverage corporate assets to leverage the sudden interest in the telemedicine arena?
Well, I think my opinion is that we need to think of ways in which a company distinguish itself, and at the same time, the company is able to come in through a mechanism that where they can leverage each other's strengths, even the competitive strength. And I'm seeing it based on my work in other areas. When internet telephony came in, they were having a very hard time penetrating the market. So we at MIT set up an internet telephony consortium. And in a consortium, basically, we asked each of these companies to pay less than what they would spend on the next fully paid professional in the company and the overhead involved. We took about 10 such companies, they joined us, and through this mechanism, because we pay lesser to students, we were roughly able to do about 20 man years worth of work. And we played the role in terms of trying to open up some of the barriers which were there. Like one of the major barriers which was there is that most countries, the government was disapproving the introduction of voice over IP or internet telephony. And we had to basically tell those governments that whether you like it or not, this technology is going to come in. And you can either approve it and regulate it, or you can just have it as an unregulated industry like drugs or something else which you don't want. And the reason the countries were opposing it is that the telecom giants of those countries were going ahead and saying it should not be done and all. That was the resistance which are coming in. I remember in the US also, when I was trying to develop this consortium, the biggest impediment to it was one's the biggest telecom company at that time. And the person came to the meeting very opposed to the idea. Everything I used to say immediately, there was a rebuttal. I would say the prices will come down. No, the prices will not come down. Competition will help. No, the competition will not help. So finally, after half an hour, I got tired. And I said, well, if you think this idea of having this consortium is so bad, then why don't you leave the room and we'll go without you? And he says, no, I think the idea is totally stupid, but if you go ahead and set it up, I'll be the first one to join it. So again, I see this, we may laugh on it. I've served as an advisor to a dominant country. We have 40% of the banks have gone bankrupt. And again, we were trying to show to them how sharing of information is there. And everybody said, yeah, I'll see the information from other organizations, but my organization, nobody will see. And we laugh on these things, but the bigger the company you are, the bigger the country you are, it's more difficult for you to accept this mechanism. And that's what we think we need to realize in this case, that if we have to progress, we'll all progress together, or we'll continue to make very, very slow progress in this area. And that's what I advocate is the area where the companies, the universities, the government should actually work together. And there are good models of it. The W3 consortium was an example of it. The work which we did previously on check processing, internet telephony, and others, Lean Aircraft Initiative at MIT. Those are initiatives. And there have been initiatives driven by other universities as well. I do not think, from what I've seen so far, that it should be led by a national government, this kind of initiative. I would have thought the World Health Organization was possible, but having served as an advisor at World Health Organization in the past, and I had very pleasant experiences, what we proposed was ratified by over 100 countries of the world. But given the issues related to it right now between the US and international organizations, I would not suggest it be done entirely by the government sector, entirely by the industry, or entirely by any other single sector. That would be my recommendation. We need a strong anchor point, and then we should work as a team. That would be my advice.
In terms of your research, can you talk about anything that has particularly intrigued you or surprised you, that anything you've encountered throughout what you've been uncovering?
Okay, well, let me give you two examples and let you think about them. The first one is that the technology that is used today for processing checks, reading them and processing it, that came, the basis of it came from my group. We hold the patent on that work. And we tried to apply it in different countries, and we had to start with a small Asian country first, and then England, and the US only accepted it later, and as a direct consequence of 9/11, within a few days they accepted it. But as we developed this technology, I talked to a medical group and I said, you should go ahead and use it also in medicine. We actually developed a prototype system to show to you how it can be used in medicine. And this person was the CEO of the largest health insurance company in the country. And after seeing the demo, he said, I have two questions or two concerns. The first concern is, you've shown it in a lab environment. Will it work in real life or not? And I said, that concern is very genuine. I entirely agree with you. We are in a business similar to a Wright brothers plane. We show that a person could fly, but we don't carry commercial passengers. So he says, don't worry about it. If it doesn't work, that's fine. We have projects which don't work. But my real concern is, what if it really works? What do I do then? Every part of the healthcare sector, they have a lot more profits. We work on a very lean profit margin, less than 1%. The thing he didn't add is that their budget is probably the largest because they're an insurance company as opposed to a hospital. We are a very lean and lean company. If this comes in, I'll have to fire a lot of people. I'll have to start adopting it. I'll have to do other things. That bothers me much more. So this kind of attitude, which is characteristics of organizations with the fourth state of evolution, which I told you, is very much prevalent in the sector. And that's been one of the experience, and that's what we have tried to do over the years to contract it by writing things in technical journals and business journals and medical journals and law journals, just to try to show all of them that we really need to work together to go to the next step. I can give you another example, which is even more delicate. This is a case where a couple went to California, getting a very good job in LA. The lady had a fall at the Marriott Hotel. Um, she's taken by an ambulance to the city hospital, to one of the city hospitals, very eminent one, if I may say so. And the hospital basically goes in and say, we only take care of our own patients, we don't take care of others. They spend the next 4 hours trying to send the patient to another hospital. None of the others would take her because it's illegal by state laws, federal laws, and others. And finally, the family is shipped to Boston, and the emergency surgery is done 10 days later. And by the way, the person involved in this incident is me and my wife. We were the ones who were affected. And then the government officials say, we'll take very good action, we'll take corrective action. And the government said they'll do an inquiry. And they did an inquiry, and the extent of the inquiry was, we are going to close it because the particular hospital has responded to your message. We don't think it's worth investigating further. And what the hospital has said is, well, we did what we have to do. If you're not satisfied here, go to a small claims court. That's what they said to it. So even now, I think that hospital is probably doing the same thing in the coronavirus pandemic. This is the way which they are doing it, which will not happen anywhere else in the world. So I'm just giving you an example. So we have taken these as research cases. How can we enhance the safety and quality of healthcare? How can we have patient-reported outcomes be used? How can we optimize the EICU environment so that the EICU model can be used around the world right now to do pandemic work? We have people who are kept at a distance from the doctor. The patients can be in any country. The doctors can be in another country also. How do we work as a global team to work together? Those are the areas that we've written about. Those are the areas my students have written about. All these issues which are currently the barriers to it. We have not developed any new drug. We have not developed any new technology, but we have tried to refine it. We have tried to innovate it. That's where our skills have gone, and that's where our expertise is mainly.
Thank you so much for that, Amar. I was wondering if you had any final comments you would like to share with everyone as we start to wrap this up.
No, I think this has been very interesting area. I think one of the things I'd like all of you to think about is that if you have to progress in this area, we have to think about what we can do in those 4 areas: the knowledge acquisition, the knowledge discovery, the knowledge management, the knowledge dissemination. A lot of our work is on the web. Feel free to use it, cite it. We want you to be able to apply it to things. And also, I would go ahead and say that please think about what can be done in the area of interoperability. Right now, there are about 160 initiatives around the world which are trying to look at the area of interoperability. And each of them, they are either looking at a small geographic region, some of them are just nationwide, some of them are really great in terms of what they've done. The Europeans have thought about it a lot. At one point, they used to say that anything should be only national in nature. They have realized that 20% of their population crosses the national border every year. During the privacy restrictions, they could not send this information back and forth. Their costs were going up. Their speed of delivery of services was going down. So they want to work with each other in terms of how to share this information in a meaningful way. We need to think about the same thing here, how it can be shared in a meaningful way. We want to make it agile. Then we have some kind of systems which have been designed for very specific diseases. We have a different system for pharmacy. We have a different systems for drug development. We have different systems in labs and all. We really need to think about how they can integrate it together, what kind of synergies can be done. Things have progressed, but things have progressed slowly. At one point, a doctor was only allowed to give a prescription which was valid in one's own state only. I believe there's still 1 or 2 states in the country which still require that to happen, but the bulk of the states today accept prescriptions from out of state. And therefore, we need to think about what can be done. I'm also disappointed at the efforts which have been made in the area of interoperability. There have been committees which have been set up, which have involved politicians, they've involved medical doctors. They've also involved some of the people from the big EHR companies as members of it. But I don't see a single person on those committees who's a top-notch computer scientist who's not a doctor at the same time. The only computer people who are there are people with dual affiliation with computer science and medicine. We need some people who can really think about these issues, people who have been successful in other industries to really go ahead and do it. It's a matter of cost, it's a matter of safety, it's a matter of lives to do it. And one of the persons who has been there for many years, who's CEO of a major company, recently the federal government tried to have some better access for patients to receive their own information. Right now, the EHR companies think that they are the owners of it, and patients will request them, and hospitals make it difficult for people to receive information. And I should tell you myself that for 8 years, I used to spend part of the year here, part of the year in Arizona. And every time I had to go, I would be told by the doctor's office, no, I can't get that medical information. And then I would say, oh, I'm Dr. Gupta. And they said, sorry, doctor, we made a mistake. And afterwards, they realized I was a PhD doctor, not a real doctor, but a phony acronym for phony doctor, or whatever they like to call. We have characterized as PhD doctors. So that makes a difference to the attitude in the financial industry and all when we work. Nobody ever asked a question whether you're a medical doctor, but this area is very sensitive. And by the way, that same company, when the government was trying to make it more public, they went ahead and organized a public campaign, and that's why I'm giving this information. It was a totally public campaign, asking people and asking hospitals and to go ahead and petition the government and tell the government it should not be done. And some of the best hospitals from the Boston area have actually signed on that petition. So on one side, the same hospitals are saying we're doing a great job, we are trying to help the patients. On the other side, some of these same organizations are acting as barriers to change, barriers to sharing of information, barriers to it. They all have their things, and it's a documented thing in literature, and you could go ahead and do a search on it. 50% of the blame on information sharing has been given to the EHR companies themselves. They were the ones who were deliberately blocking the information. It's a concept of information blocking. And 25% of the blame has been put on hospitals, that they don't want to share information because they want the patient to be part of that hospital, only use their facilities and nobody else. If we have these kinds of forces taking place, then how can we have economies? How can we compete with the world? How can we have performance and quality? So these are some of the impediments that we should look at. And so far, everybody had their very kind of standard niches. They felt comfortable with operating with their niches. The dominant paradigm was, well, we know the system is bad, but our part of the system is great. Don't touch our part. How dare you touch our part, touch the other parts which are inefficient? That kind of attitude is not going to make any changes. We need some kind of improvements, radical improvements, and that's where the crisis comes in important. And that has been some of the topics of my recent talks, which are available online at CSAIL, saying how does this crisis actually serve as a catalyst to having change in this area, to having improvements in this area. And that's what you may like to consider looking at.
Amar, could you please discuss a little more about the interoperability of the electronic health records system?
That's a very interesting question. And let me start by defining these two terms and clarifying how they're same and how they're different from each other. The electronic health record system essentially started from the idea of how to do patient billing. That was the sole purpose of it. So they came up with a way in which a hospital would bill, keep some information on what the patient's name was, address was, what particular procedures were done, and they would then use it to send it to an insurance company. In an electronic health record, the idea was not to have comprehensive information about the patient. There was no idea to have a lot of symptom information which was there, but the idea was only to have the patient's information in a unique manner. And again, it's subject to various privacy rights. In some cases, you could use a national number in the country. Some cases, many cases, you could do it. So there were new numbers which were formed for it, which aggravated the problem of keeping it, but that's what the focus was. It was not meant to be a repertoire of the patient's history over. So then these companies came along and they said, instead of each hospital, you doing it on your own, why don't we try to help you for it? And that's how these EHR companies were formed, essentially from the point again of helping with the patient billing process. In turn, we also had the World Health Organization working with some standard definitions for diseases, symptoms and all, and they came up with the notion of ICD codes, which was uniform codes. And while there was disagreement between different sites to use it, the ICD codes were the ones which have been used as one of the basis for judging how much should be paid on it. There are all kinds of codes for this there. From what I've heard from other people, There are codes even for things like problem created because of mother-in-law, or things like that, which you and I would not take it as a diseases anyway, but these are kind of codes which are there. And again, things have changed over time, so the example I may have given it may or may not be valid. The interoperability aspect really depends that as we had new devices coming in from different manufacturers, how do we share information between the different manufacturers' devices? In the olden days in the computer industry, IBM did a tremendous job as being the largest single player, and therefore whatever standard IBM came up, that became the de facto standard for a long time. And there were bodies which gradually came in from IEEE and ACM and others to do it. So here again, we have this dichotomy taking place that we have different parts of the industry which is coming up with different standards. DICOM, for example, is the one for medical images. It was one of those cases where the industry companies like Philips were on it, others were on it, on the board. There were people from technology side, it's come on. And it's lasted for a fairly long time, the DICOM standards for imaging. But in recent times, there have been a lot of objections to it, saying that it doesn't provide enough security and privacy for the patients, and therefore we should think of new standards. So we have these two extremes taking place. One is these EHR companies coming up, and again, the attempt at this point was just to fulfill the needs of the banking, of the billing agency. It had no interest in giving records for the patient, and it had actually no interest even to give information to the hospitals and doctors so that they could have comprehensive one. So most of these hospitals went ahead and set up their own systems, internal systems, where they would have patient records, and the patient records would have things like a nurse would say, I gave John a glass of water. To you and me, it means nothing, the word John. But again, if it is for a patient case, it again gets bound by HIPAA. Unless that word John is taken out, it's considered to be still an identifier record and what time the patient was there. So a lot of conventions came in. Coupled with it, we have the situation where pharmacies had their own system, both in terms of how they deliver the drugs, what happens. At one point, there were different ones for different states. Over time, they've come together and become much more aggregated. We also have different systems for opioid use, which are used as a national one. We also have systems for mental health information, which in many cases cannot be stored with patient information, other information bound by even more stricter guidelines on privacy. So all these pieces of information were fine when the patient was going to one place. If you were going to a hospital X, the hospital had a billing system, had a patient information system, had their own internal systems which are there. But when it came to a patient going from one hospital to another, it created a problem because the records would not go easily. Some they would claim were in formats on computers which could not be shared. And I remember at a hospital where there were two units of it about 5 miles apart, they basically said nothing else works within our hospital. We actually fax the information from one place to another. That's the level of how primitive the thing is. So when we talk of interoperability at this point, we have to really think of aggregation of all these ideas. And right now we have fiefdoms in each of these areas which is taking charge. We have people in EHR industries who some want to have more synergy, something no, we should not have more synergies as the later thing is there. When we had checked out earlier, the states in the US defined what were the rights who owned the data. At that time, there was only one state in the country which clearly defined that the patient data, the ownership is vested with the patient. No other state had clearly defined who owns it, whether there's the patient, whether there's the EHR company, whether there's the hospital. So essentially, it was might is the right kind of an attitude. The hospital had it, the EHR companies, and the patient was the one in terms of low priority. Things are changing around. We are getting more synergy, but at the same time, these fiefdoms are still very much operation. And my vision is that the way these fiefdoms are developing, we will not have any synergy in the absence of something at a global level. And I don't think it's happening through the World Health Organization or any country doing it. So the way I think about approaching this problem is exactly what I did in the case of the Air Force. What we proposed in the case of Air Force was that when we had 30-digit part numbers from Air Force, 20-digit part numbers from Army, 15-digit from Army, from Navy, they would have tried to have a 100-digit part number, which would make things even more complicated. Instead of that, I give the example of how one deals with currencies. This was quite some time ago where there were different currencies in Europe. But let's take an example which would be equally valid today. If you're trying to convert, say, Cambodian currency into Peruvian currency, and you're trying to design translators which do it, then you'll have to do it with the number of currencies multiplied by the number of currencies. So if there are 200 currencies in the world, you need 200 times 200 converters. To an level, convert it first to dollars or pounds, and then we convert the dollars and pounds into the other currency. So same thing here is, how do we have a mediation approach which can be used across organizations, which can be used across sectors. So how do we have something which will work for hospitals, how it will work for IoT devices, how it will work for pharmacy, how it will work for many other things. And in order to do this, we need a leadership, and the leadership basically has a role that act as a super coordinator of all these coordinators. We have coordinators in each of these industries who are trying to do things for their own niche, but we have virtually nobody who's looking at the total situations, acting as the global coordinator in terms of fostering these work. And to some extent, the W3C had to use a mechanism somewhat similar to it. But today, when I talk to the WC3 people, they have not generally been interested in getting this arena. So we have a major opportunity of doing it. And the way we do it, again, is to have a consortium model, which we have used in check processing, where we had sponsors, National Westminster Bank from England, Sumitomo Bank from Japan, Deutsche Bank from Germany, Bradesco Bank from Brazil, Citibank and Bankers Trust from the US. They each funded some of the initial work, and they all felt they got a lot more out of it. We did the same for internet telephony, and that's what I would advocate is the right way of proceeding forward. Try to do it. And in some ways, where people may disagree, people think this work should only be done by doctors and medical institutions. In some way, at least, I found that when I did work on check processing and I did work on other areas, the fact I was not from their field actually made me much more independent and much more willing to work with people. And therefore, I think, again, the fact we are able to be in Boston area, the fact we have a lot of organizations here interested in this area, that might be a good way to do it, whether we do it through the mechanism of MIT, whether we do it through Harvard, whether we do it through Boston University, whether we do it. But I think that may be a good starting point to think about for the local community, whether we can play a role on it and essentially take our innovation ideas and get them deployed all around the world. So this is a question which I think is very critical, and therefore I've given you an extended answer. And if anybody is interested in this area further, I'd be very pleased to interact further with a person through phone or Zoom or email or whatever. Thank you very much.
Thank you so much, Dr. Gupta. Thank you everyone for attending today's presentation. I think we're about done right now. So I want to say thank you to everyone for attending.
Yeah, and you have the address for people here who are the organizers of this event. You also have access to information through the net and others on work which has been done. So please feel free to use that. And I hope if this discussion leads to any change, whether it's in Massachusetts or another state or another country, I would feel that it's worth it. And our people have been very good in terms of doing it. I should tell you that one of the students who worked on the project, when we did work on image processing, a lot of my students were very upset why we are giving up so much of our technology away, why are we putting it on the web and all, don't you care for money? And I said, some things are more important than money. This is not the kind of technology at that time we could just go ahead and offer a product. I have to work with governments and all. And if I have to work with governments, I can't be offering my own product because then I'd be competition and conflict of interest. And we went ahead and did it. And once it came in and that was successful, this student went ahead and started a company in the same mode of doing things for free for society. And his name is Salman Khan, and he started Khan Academy. So that's one of the derivatives. So I'm hoping that some of you in the audience here will take those ideas, take it further in your own organization, think of what can be done in your organization, your country, your society, and hopefully we'll all be able to work together and change the situation so that when the next pandemic comes in, we can address it better, we can be more productive, and we can deal with it in a more effective manner. Thank you very much.